Assalamu alaikum. Good evening from Pakistan and good morning to America. And I'm really very excited today for this public health interest group because we are going to have a very exciting and informative session on a very, very important topic, COVID-19, the future of COVID, vaccines and variants. And for formally welcome our distinguished speakers, I would now like to invite our official from U.S. Embassy in Pakistan, Ms. Elizabeth Smith. So over to you.
Great, thank you. Thank you so much. So good afternoon, everyone, and greetings from the U.S. Embassy, Islamabad. Welcome to the Pakistan-U.S. Alumni Network Public Health Interest Group session, The Future of COVID, Vaccines and Variants. We're so grateful for your time and interest in this very special event today. We hope to learn throughout our discussion and engagement with our special guests today. I just wanted to introduce myself and today's program for you. My name is Elizabeth Smith, and I'm a public diplomacy officer here at the U.S. Embassy in Islamabad. Today's program will include a discussion panel from renowned public health experts on the subject of the future of COVID. It is an incredible opportunity to hear firsthand their perspectives on this super pertinent topic for us all. So without further ado, on behalf of the U.S. Mission in Pakistan, the State Department in Washington, D.C., and PUAN in Pakistan, we are thrilled to welcome moderator Dr. Rakshinda Perveen, speaker Dr. Amin Malik, and speaker Iram Zaidi. Please allow me to introduce today's moderator. Dr. Rakshinda made a transition from clinical medicine to public health in 1995, when she was hired as the first medical field trainer for a pilot social marketing family planning project, Green Star, by PSI, DC. Since then to date, she is actively contributing towards different aspects of health management and policy through gender and intersectionality lens as a free thinker, development expert, writer, researcher, teacher, mentor, advisor, activist, and public policy advocate. She has to her credit a number of academic and journalistic writings on the issues of reproductive health, adolescent and youth health, gender-based violence, community engagement, policy priorities, HIV/AIDS, health system strengthenings, and an award-winning pioneering TV series on issues of health and gender, which aired on PTV from 1999 to 2000. She's the recipient of many prestigious fellowships and awards, including the Biari Fellowship, Brown University, U.S., Distinguished Alumni Award, PUAN, and an Acknowledgement of Service Award by the Ministry of Population, the Government of Pakistan, in 2006, besides being among the top 100 women experts in global health in Pakistan. Currently, she's dividing her time between freelance work and leading an indigenous think tank, Apna Wallet, meant for psychological financial empowerment of all women. Next, I'd like to welcome our alumnus special guest speaker, Dr. Amin Malik. Dr. Malik is an infectious disease epidemiologist and a postdoctoral associate at Yale Institute for Global Health. He completed his PhD in epidemiology from Emory University, has a master's of public health from Johns Hopkins University on a Fulbright Master's Scholarship, and an MBBS from Aga Khan University. His work on COVID-19 includes understanding risk perception, vaccine acceptance and hesitancy in different populations, behavioral interventions to improve vaccine acceptance, voluntary behavior in response to increased risk during the pandemic, and disease surveillance. He has published extensively on these topics. His work also includes contact investigation and use of preventative treatment for exposure to drug-resistant tuberculosis at home, and shorter regimens to improve uptake and complete. Aaron serves currently as the Deputy Coordinator for Program Results and Impact Monitoring for Epidemic Control, also known as PRIME, at the U.S. Department of State's Office of the U.S. Global AIDS Coordinator and Health Diplomacy, which leads and coordinates the U.S. President's Emergency Plan for AIDS Relief, PEPFAR. She's an epidemiologist by training and has been part of the Global AIDS Coordinator and Health Diplomacy leadership for over 5 years, working on PEPFAR's global HIV and AIDS efforts. She's devoted her career to the control of infection, implemented innovative infectious disease control strategies using granular data, establishing innovative health information systems, and community engagement. She has led the global health data revolution and is recognized for her focus on epidemiologic impact and data use. Iram graduated from Emory University and has a Master's of Public Health degree in International Health and Epidemiology and a Bachelor's of Arts degree in Psychology. So it's my honor to be here with all of you today. Over to you, Dr. Perveen, to begin the program. Thank you. I think you might be muted, Dr. Rikshinda.
Can you hear me now? Hello? Yes, thank you, Mrs. Smith. And our first distinguished speaker is Ms. Iram Zedi. As she has been introduced, but if I may add that she is a recognized leader, in dealing with data and epidemiologic data. And Iram, you have 20 to 25 minutes for my only 200 something questions, but they're condensed into 8 to 10 questions. So the first warm-up question is all about, COVID-19, White House Corona Task Force. So tell us that you have an extensive experience of working for HIV and AIDS. So how this experience is translating into your current assignment, and how do you inform the task force? What are the mitigation strategies, both at national and local level? And also tell us that why this pandemic is so different. I mean, what we didn't know about other pandemic that we know about this, or vice versa. I mean, these are questions.
Thank you. Well, let me first say thank you all so much for inviting me today. Really excited to talk to the embassy community and the Pakistani community in Islamabad and abroad. I think one of the good things about the pandemic is that we can all connect across borders so much easier than we have ever been able to before. As Elizabeth said, my role every day, my day-to-day role is leading really all things data across PEPFAR. We serve over 60 countries across the world. So we are already, it's a 15-year, actually it's an 18-year program that President W. Bush had started, and our experience working globally, I think, really lend us to be able to adapt appropriately to working in this pandemic. But things like Zoom and WebEx and all of those functionalities that we have now weren't as available. So it's great that we can connect with our international colleagues in a more meaningful way. But I would be remiss if I did not start off with a few slides and with data to answer, I think, a little bit of your first question. I think it's important, and I'm going to just share my screen. Hopefully everybody can see my slides, and just a few slides to frame the issue. So trends matter. Trends in cases, trends in testing, trends in vaccinations, and triangulating all of that data is really critical. So I'm just going to show a snapshot into how we look at the data here at the Office of the Global AIDS Coordinator across our countries. And for this discussion right now, I've only picked some select Western Hemisphere countries and really looking at the trends in cases since the beginning of the pandemic. Now, what's informative, so this starts in March. These are daily cases per million population. What matters is really the trends. We know that COVID-19 is underdiagnosed. We know that testing isn't available to everybody that needs it. But as we think about mitigation, as we think about vaccines, as we think about populations that are affected, understanding where, and obviously within each country, where are these trends trending, which populations are they impacting, and what are the perspectives at the local level about COVID. Oops, I think I have to go to there we go. So those were the cases and looking at the cases over time. The other thing that's been amazing about this pandemic is that the global community from all walks of life have come to answer the call of what is this pandemic doing to the world. So people who don't have a public health background have come. People who are data scientists for business, they are trying to make money out of data, came to the call and came to answer this pandemic. Genomic sequencing really stood up very quickly. That never happens. It's a very deliberate, scientific, moderated approach to sequencing. But what we see, and this is just a snapshot for the same countries, that in 2020, we really had the wild type virus circulating across these countries that I have the trends for. So for maybe small font, the United Kingdom, France, Germany, Canada, and the United States. As people started, as countries, and really, I would say, independent universities started sequencing, making their sequencing data available, more information started to come out about what the current virus type is circulating. So early in January, the United Kingdom started having data that we have a different type of virus circulating. And at that time, that was Delta. And it was starting, sorry, no, that was not Delta, that was Alpha. And it started to circulate more and more. And virus fitness is very important. Virus fitness means that not only can this virus be more severe, but it can outcompete all the other types of viruses that are circulating. And so you see France, very little genomic sequencing happening, Germany, Canada, and the United States. Fast forward to April, we see now Alpha is the predominant strain. June, Alpha is a predominant strain, but guess what? Delta is more fit, and it's a survival of the fittest. And so by September, where we are now, we see that Delta is the predominant strain. My concern, though, if I was to just go back to this next slide, this uptick in the United Kingdom, I think there's something else going on here with the new variant that we have not been able to detect in any meaningful way. But I'm sure in the next month or so, I mean, we already hear about Mu and we're hearing about Epsilon and others, but we're going to find out that there is a new variant that is popping up here that is more fit than Delta and could outcompete the other viruses. So these trends and trying to explain and understand what is happening, what has changed in terms of mitigation, what has changed in terms of the variants, what has changed in terms of vaccinations, hospitalizations, these are all so important to understand at the local level. I just want to show again, we lead a program that's across 60 countries. Just want to share very quickly in Uganda and Zambia that non-pharmaceutical interventions matter. In Uganda and in Zambia, both at the end of June, they started to see an increase in cases, a rapid increase in cases, and even higher than the previous holiday season. It took a while for the governments to put in policies that were finally enacted, but when they were, cases peaked within 2 weeks. We have an example in Namibia where it took very long for the government of Namibia to put in effective policies. And the longer you wait to implement these policies, the longer it takes for the cases and transmission, hospitalizations, and deaths to come down. And then finally, I just wanted to provide a snapshot for Pakistan and the countries surrounding Pakistan. So looking at the tests conducted here in purple, we have India, in green, we have Pakistan, and in blue, we have Iran. Looking at tests conducted per case confirmed. So are we getting and identifying the asymptomatic cases so that we can prevent the severity of disease, the hospitalizations, the deaths? Or are we really still only diagnosing the symptomatic cases? And here we see really a smattering. I think for the most part, we are only diagnosing the symptomatic cases because those are the commodities and the availability of resources that we have. You can see then over on the right, this is the daily confirmed cases. We see in Iran, they had a high peak, again, triangulating their cases with where their testing had gone over the same time period is important, but we don't see that bump in testing that corresponds here. So you know that wasn't a testing campaign that identified more cases. And then finally, looking at the share of people who are fully vaccinated. And does this have an explanation then on the decline in cases? Does this help us understand which populations, if we disaggregate the data here about which populations, which geographies, were cases more in the urban areas? Were they among rural populations? Was it among the more elderly? That should inform our vaccination campaigns and where we should start vaccinating in a tiered way. So I just wanted to share those few slides. I think it hits key points in the questions, the few questions that you asked me. But I would say that all of this work in COVID was really informed in my experience in working with HIV/AIDS. As all of us know, HIV has a lag time. Somebody can have HIV, but does not feel symptomatic for 10 years. They do not know that they may have this virus that is living in them. They may have a blip at that time of acute infection. People say, oh, maybe it's the flu. Everybody thinks it's the flu. Always it's the flu, but we know it's not the flu. And then 10 years later, they can have their CD4 drop. They can have a rebound in viral load. So COVID is just a truncated version of that within like 10 days, not 10 years or 20 years. And the key piece about this, and this is where the stigma matters, people's understanding about why this is important, is that this virus is so rapidly transmitting. There are so many more asymptomatic people who have the virus, who don't know they have the virus, and they're just transmitting it. Now, even if 1% of those who have the virus, or 2% of that have the virus, need hospitalization, need remdesivir or monoclonal antibodies, our hospital systems, not just in the United States, but around the world, are not set up to treat 1 or 2% of the population at one time. They can treat people over time, but not at one time. And that's why this virus matters. And that's why identifying the asymptomatic cases, so that we don't have to divert the people who had a heart attack, the people who broke their leg, the people who, were scheduled to have, their prostate, addressed. Those are the things that are putting all the health of Americans and in every other country at risk. So that's why this disease matters. So let me pause there and see if there's specifics that you'd like to follow up on. I know I said a lot, but let me turn it back over to you, Dr. Lakshanda.
Yes, it was quite comprehensive, and actually you covered some of the questions that I was about to ask, for instance, about stigma and on the trends. That was very interesting, so I'll come back to it. But we are hearing one word very often since the advent of this pandemic, that is new normal. So tell us, is this pandemic and living with it and tolerating its variation, its misbehavior, all this would be a part of new normal? And what is like the thinking within the scientist community when they're seeing the mutations, the variants, what is the picture? What is the feeling?
These are great questions. And this is where I come back to, when I was on the task force last year, we had very robust discussions about the reproduction rate for this virus. And is it the reproduction rate of the flu? And everybody wanted it to be the flu. And when you're focusing on everything that you've planned for this pandemic, then you're working in a very focused way and not looking at, okay, is this actually behaving? What we saw on the cruise ships, people went to fomite transmission rather than thinking about, is this a different reproduction rate? And we know this is not fomite transmission. This is a highly transmissible virus. Now I'll talk about flu for a minute, because I think there are pieces here that are corollaries. So with the flu in the United States, and maybe just in the Western Hemisphere as a whole, we have a new flu vaccine every year because there are new strains circulating. We look at what is circulating in South America. By mid-fall, then we have a new type of formulary for the influenza vaccine. As I was learning more and more about this, again, I've focused my entire career on global HIV, but when I came back to understand our flu vaccines in the United States, maybe even 30% effective, that everybody is signing up to get that flu vaccine every single year. So I think from a COVID perspective, that is exactly where we will be, right? Every year there will be different strains circulating. Every year we'll have to get that annual COVID. I'm sure there'll be a different name for it. They'll be rebranding and so that it's more palatable, but it will be similar to flu in that way. And what is our new normal? Again, when we travel, and I'm sure many of you travel to Thailand, Vietnam, Cambodia, a lot of our colleagues in that part of the world are always wearing masks. They're wearing masks on the plane, they're wearing masks in their daily travels. And it is two things. There's one, the air pollution, but then also SARS. And that became their new normal after SARS, and wearing masks all the time. Now, depending on where you live in each of our countries, you may live in highly densely populated urban areas where you are wearing a mask every single day. But you could also be in rural Georgia or rural Montana, where you may see 5 people once a month. So having those nuanced communications is so important, because what happened in the United States last year was that everybody saw the outbreak in the Northeast, but the Northeast is very different than the South. It's very different than California. So they're like, that's the Northeast. That's not me. That's not going to happen to me sitting in Arizona or me in Montgomery, Alabama. But it did. And this virus crossed every state border, every jurisdiction. And I think it was unfathomable to people who don't watch daily trends to say, this is exactly what's going to happen. And so there was a lot of education. There were a lot of non-public health people. Obviously, our president had to, be the leader. Economics is a driving factor for every single country, and wondering about the economy and wondering about public health. And it should not be an either or, but that is a very, very difficult situation to be in. The other difficulty is local public health only has so much capacity. Local public health, changing mitigation, changing communication, educating, it is a big, they haven't had to operate like that ever before. STIs, rabies, maybe HIV, those are the types of things that hit in the United States at the local public health. And by local, I mean city public health or county public health. And so managing data, communication, the ever-changing nature of this virus is a lot to manage. I don't think we actually know what our new normal will be, but definitely vaccines, masks, depending on where you live, the masks, testing, testing, and more testing, because I think people want to do the right thing and making services available in a way that they can be empowered to know if they have COVID or not, or flu or HIV. I mean, we can name any infectious disease. I think if people have the knowledge about their own status, they will take appropriate action. I'm a strong believer in that.
This is very, interesting, that what we know, what we don't know, and how sufficient is the information. I mean, research is not, there's no monolith in the community of researchers as well. So there's a lot of conspiracy theory and blah, blah. But you have talked about stigma, you have talked about economic interest. Do you think that social constructs and social determinants of this current pandemic and politics of identity, they would also be modified, or they would be somehow integrated in the new normal? Or, I mean, what is your opinion? Because you have worked on HIV and AIDS, and you have seen then how the world, changed because of this particular factor. So what is your take on this?
So the social determinants of health for HIV and for COVID, and I'll talk two ways. I'll talk about the United States, and then I'll also talk globally. What I've learned is that there are systemic pieces, systemic health barriers that impact really everybody except people who live in urban settings and can access healthcare. The moment you get out of a metropolitan area, everybody has barriers, be it, and I'll talk about the United States, be it white, be it Black, be it important Native Americans. We can come back to the Native Americans in a minute. Be it Black, be it you have money, you don't have money. We don't have the healthcare delivery system for rural populations in the United States. And I think that's one of the reasons we also saw a very big opioid epidemic in rural America as well. On top of that, then, you have further disadvantaged populations that are the frontline workers. I'm not saying they're disadvantaged because they may, because of financial or otherwise, but these were our frontline workers that we needed to have in the hospitals. These were our frontline workers that we needed to have in our supply chain for our meat supply in the United States. These are the frontline workers that we needed to have in our grocery stores. And we did not have all the supplies on hand for PPE, for testing, normal working conditions in a factory, or people are very close to each other. So those risks and understanding, just changed what people could do. There's much to be said. Over the past 6 months, I've been really looking at rural communities, and they're not even that rural, but where they're working in hourly jobs, in factories, in plants, they really have no other options. They have to go to work every single day to put food on their table. The United States government gave stimulus checks to help people not have to go to work every day. But we truly have to think about each of these populations, the way they live. And on the HIV side, that systemic risk and barriers are there as well. But on top of that, HIV is so stigmatized, and there are specific risk population type of level. So men who have sex with men, sex workers, in many countries, just being HIV positive, you're stigmatized, and you're stigmatized for life then. Here you have a disease that may last 10 days, 20 days, and then you move on. But for HIV, it's for life.
Okay, so it's still so many millions need to be vaccinated. So let's talk about the efficacy of the vaccines. I'm not talking about the politics of vaccines. Why this vaccine does, some kind of, if I can use this is a non-public health term, cha-cha, it goes forward, hey, it's effective, and then, oh no, it's not effective. So please tell us, what is exactly happening? You know everything, and can we get a magical vaccine, or people of my age, they have to go for the boosters and what else? I don't know. So please, on vaccines, your honest opinion.
Sure. It goes back to that one slide that I showed about how the virus strains are changing over time. So there are a few things on vaccines. Again, this virus has taught us a lot. If you remember the conversations of last year, the conversations were, will this vaccine prevent transmission? Will this vaccine prevent severe disease? Will this vaccine prevent death? What we've seen this vaccine do is prevent severe disease and prevent death. It will not prevent transmission. And I am so keen to understand how many viruses we're already carrying on our bodies every single day, right? We carry probably millions of viruses that we don't even know. But they don't cause severe disease, so we're not worried about them, right? So we're going to learn a lot about virus transmission as host carriers, and then the asymptomatic to symptomatic to death. So going back to then the flu, so I think it will become an annual shot, an annual COVID vaccine. What is a little concerning to me, if you think about those case trends that I showed, that these cases surge in summer and in winter. Flu only in the United States only surges in like the late November to March timeframe, and that's primarily because kids are in school and they're taking that virus and taking it back home, and there's all this transmission. But there isn't transmission in case surges during the summer months. So understanding that and what that looks like, and how, because you will have waning immunity from vaccines normally. Nothing is 100%, right? There is nothing that's 100%. And again, in any given year, the flu vaccine may have 30% efficacy, but that's okay because the severity of disease of the flu is not like COVID. The transmissibility of the flu is not like COVID. So those comparisons are important, but we will have to have a new formulary for a new boost. We call it a booster, or just the annual COVID shot. But I'm concerned about the summer months and what the timing of that would be, and where we can get the most lasting immunity from a vaccination. But everybody was waiting. Everybody thought the vaccines will be the answer, and this will be in our rearview mirror. Unfortunately, that is not where we are right now. And in the United States, testing has now really has picked back up. There are at-home tests that people can take. They're, trying to make them more affordable. But I really hope, and this is what we have been emphasizing in our global HIV program, that we have more patient-centered services. Our whole medical situation, and I know I have many providers on the line, so I don't want to offend you, but those services are centered around the provider, and when the provider is available and at the clinic in this very specific way. And that's hard for people who are working an hourly job, and they can't access that service because they have to pick, do I get paid or do I go see the doctor? That is not a place anybody should be. So I'm hoping that with these at-home tests now, I'm anemic and I hate having to go in and schedule, number one, I'm usually in another country. I'm not even in the United States. Like, get it scheduled, then go to the lab to get my blood drawn. Like, can I get an at-home anemia test so I can just see what my levels are? instead of going through all these different, hoops and whatever to figure this out. So I'm hoping there's a revolution in the way we provide prevention and clinical services to individuals. I know I went beyond your question, but anyway, back over to you.
I mean, it's a great sharing, and a lot of information is yet to come. But my last question, and then I will invite our wonderful audience to throw a couple of questions, because I'm also looking at the watch. So you talked about affordability and accessibility and acceptance of the vaccine, and you showed trends in different countries as well, besides trends within the United States. So how do you see the global readiness? What is the state of global cooperation regarding addressing this pandemic? What are the barriers as well if there is not the desired level of cooperation?
I would just go back to economy. That is the number one driver. And I'll just talk about HIV first for a second. And in the late 80s and 90s in the United States, many of those who were being diagnosed were Haitians. And even in the United States, they were Americans of Haitian descent. And that became, even though the scientific community was trying to just put out information about, okay, where is this disease coming from? What is happening? That then labeled a whole country a certain way. And there's still backlash today on Haitians regarding HIV. In the Caribbean, they sometimes don't even want to conduct surveillance for HIV because they don't want it to impact their tourism. And if they do conduct HIV surveillance, they're like, we do not want this data publicly available. We will react to it. We will have HIV treatment services. We will work with the populations, but we don't want this publicly known, because then people from the world who come and vacation here will be like, oh my gosh, there's a lot of HIV in this country, we will not go. So that's one very clear impact. And that's an example from HIV. Since probably within the past 10 years, and we all know that it's so easy to travel globally now. It's so easy to get from Atlanta to Karachi in less than 24 hours. And just think about viruses going back and forth now. And if you shut off that travel, what else are you shutting off? You're shutting off revenue that may be in either country. You're shutting off new businesses. You may be shutting off new cooperation. So, understanding that and working through that is I think people's, number one fear. I don't want to be cut off from the world, but if I put my data out, I could be cut off from the world. That because we can only protect the world if we know what's happening in our neighboring countries. We can only protect each other if we know what's happening across across the globe, because we can be within within a state in a new way, within a country, and across a hemisphere, and just in the matter of moments now. And that virus just goes with it. So changing that framework and thinking through manufacturing, supply chains, understanding that all of these are interlinked. The other thing that this pandemic showed that the world is not set up for, and I don't know if we're set up for it yet either, is that everybody needed the same thing at the same time. 7 billion people all did masks at the same time. Nobody was ever manufacturing at that level. And it's great now to see local manufacturing taking place. We're seeing local manufacturing happening in Africa. I know there's local manufacturing for some of these limited resources in Pakistan now. So that's self-reliance is so important. I'll just end with this one piece in West Virginia. So West Virginia is a very rural state, very mountainous. The governor of West Virginia said, I knew we would be at the bottom of every list for supplies. So we started manufacturing PPE. We started making our own clean, like they made these wagons to clean their schools with. All of the anything they could make in West Virginia to protect themselves from COVID, they did. So being resourceful and resilient at a local level, really, really important. And I see the world really changing in that regard.
Great, great. So let's see what our audience, have to ask or share. So due to time constraint, if I may be allowed, we can take 3 questions quickly and at a time so that Ms. Ramzadi can respond to all those 3 questions collectively. So anyone from the audience, from our alumni? No questions? I think you talked about everything. And everybody is like very concerned now because you also shared some inconvenient truth as well.
Knowledge is power.
Knowledge is power, and we must be equipped with this power, and this is the non-abusive power.
Very true.
Ramzadi, I'm not seeing any questions, so thank you. But before we say, you can stay here, but before we invite the next distinguished, if you have one final thought to tell us, the public health practitioners and experts in this group, regarding this COVID and vaccines.
So as public health practitioners, I would say understand what the community is facing, so that the advice, the mitigation strategies, everything that we're trying to intervene with, we actually know will fit the community's needs. We have great ideas, but those ideas are informed by many times our own experiences, maybe the experiences of a couple of other people, but they have to be informed by the community that this is meant to protect and serve. So that would be my one piece of advice. Thank you.
Great, great. And if you could stay here, we can listen to Dr. Malik, and maybe then we can have questions, because maybe some of us are waiting that let's hear from Dr. Malik, and then see what else has left for us, and there may be any confusion or more questions. So thank you so very much. Thank you so very much, Mr. Ramzadi. And our other distinguished guest speaker is Dr. Malik. Hello, Dr. Malik, and thank you for your patient listening. So from Aga Khan to Johns Hopkins to Yale, and you are an expert on this pandemic, and you have published so much, and you know all about tuberculosis. So this is very interesting. Both of you are alumni of the same university, hooray. And as you have worked on AIDS and HIV, and you have worked on tuberculosis, so you can draw some contrasts and similarities between the behaviors. But before asking about actual behavioral interventions, I would like to know your general overview about this pandemic, the acceptance, the hesitancy, the risk perception, because these are your areas of demonstrated expertise and interest. So what did you find very different in this particular case as well? So tell us some, as we say, which are often very sad things as well. So please, Dr. Malik.
Great. Thank you, Dr. Parveen. And it was a great listening to Dr. Zadi as well. Very informative talk from her. I will try to build on some of the things that have been said and some of the questions that you just referred to. Okay. So some of the distinct features of this pandemic have been that the global spread and the speed of spread. It was first detected in China in December of 2020, and then by March, it was a global pandemic, right? December of 2019, March of 2020, and then now 20 months into this pandemic, we are we are still seeing cases and spikes in different countries. So the speed of the spread has been phenomenal, but so has been the speed with which we have been able to come up with a solution. Like the vaccine has been manufactured within months of the virus being sequenced. The global cooperation with researchers making their sequences publicly available has been great. But on the same hand, or rather on the other hand, the emergence of nationalism has been a little disturbing as well. Rather, many countries, rather than taking a more global picture, have been focused more narrowly, trying to hold vaccines as some would say, and not taking the global picture into account. So those have been some of the interesting and distinctive features of this pandemic. The other thing has been that this virus, like many other viruses, mutate, and with mutation, not all mutations, but some mutations confer a fitness advantage to the virus. We saw from Dr. Zadi's slide how strains have been replaced over time. So with the emergence of the alpha variant, which had a fitness advantage over the wild type, we saw it becoming the dominant strain. And now Delta has an advantage over the alpha strain, and pretty much that is what we see in circulation in the US. All the strains that are being sequenced, almost greater than 95% of them are Delta. And the reproductive number has changed over time. So the wild type virus had people were thinking of flu, and the R naught, or the reproductive number, was closer. We don't have an exact figure, but estimates place it anywhere between 6 and 7, which might be double that of the wild type virus. So with that, there would be an increase in cases, and we saw the waves and the trends go up. With regards to vaccination, the vaccines became available late last year or end of 2020 and have been globally rolled out. Most of the vaccination campaigns have been focused, or well, the availability has been in the high-income countries, mostly in the Western Hemisphere. But even other countries have rolled out campaigns regarding it. We studied vaccine acceptance and hesitancy in different countries. In May of 2020, when the vaccine hadn't even become available at that point, we looked at the vaccine acceptance in the US population, and for a hypothetical vaccine, and it was at 67%. Even at that time, we knew that that might not be enough, given the high reproductive number of the virus that would be needed. We looked at vaccine acceptance in low and middle income countries as well, a group of 10 countries, which includes Pakistan. And we found vaccine acceptance to be much higher in that group. It was closer to 81%. It was between 80 and 81% on average. Pakistan ranged between 67 and 76%. We had a few different surveys in Pakistan, which is, again, much higher than the US as a whole, and then also higher than Russia. So Russia was another upper middle income country that we looked at. So vaccine acceptance seems to be higher in these low and middle income countries. And the most common reason why people said they will take the vaccine would be personal protection. So they wanted to protect themselves from getting the virus. That was the most common reason. And the most common reason for hesitancy were that they were concerned about adverse events and the speed of development of the vaccine. And as science communicators, we may not have helped here. We have been talking about the speed with which the vaccine has been developed and rolled out without focusing on years of work that had been going on previously, which enabled the vaccine to get developed as quickly as it was. The original SARS virus was back in 2003, 2004. The work on a coronavirus vaccine had been going on for 15, 16 years, and the technologies were being developed, and it helped us develop this vaccine very quickly. In Pakistan, we also saw there was some skepticism about the effectiveness of the vaccine, and that was another reason for why people may not want to take the vaccine. I know you asked me a question about voluntary response as well, but maybe I can stop here to see if there are follow-up questions and then come back to the voluntary response part of it.
Okay, no, thank you for this very essential reminder, because voluntary response, like voluntarism, is sort of like fading trade. But I would be very interested in knowing that, since you know Pakistan so well, where unfortunately we still have to deal with polio vaccination, immunization is becoming very challenging. The hesitancy and the risk perception is very, very high here. And it is not limited to low socioeconomic strata or rural population or marginalized communities, even apparently very highly educated people, they are skeptic. So what could be the behavioral interventions to address hesitancy or skepticism, because there's a lot of misinformations? And I would be very interested if you could tell us like the 3 biggest misinformation and the 3 or 4, most effective interventions to modify the behavior, if I may say so. So please.
Thank you. So we have seen that there are a few behavioral techniques which are really good in improving vaccine uptake. One includes a reminder and recall strategy. So text message reminders for vaccine appointments, and also a focus on that these vaccines are kind of reserved for you. So if you make an appointment, you will have a dose ready for you, has been shown to improve vaccine appointments and uptake in the US and other countries, and that is a strategy that can be used. Other behavioral interventions or techniques that may improve uptake are perceived safety of the vaccine. So focusing on safety, we know people are hesitant because of adverse events associated with the vaccine. Then trusted sources of information. If they are hearing this information from healthcare providers, from their doctors, from their nurses, people that they trust, leads them to take the vaccine. And then also, what's the perceived social norm around them? Are people around them taking the vaccine? Is it acceptable to take the vaccine? All of if improving that perception can improve vaccine uptake. We have been working with Facebook to see how social media marketing can be used to improve vaccine intent and uptake. So Facebook allows you a platform where you can do social listening. You can observe the conversation that is going around vaccine, why people are looking to take the vaccine or why they are not looking to take the vaccine. What are the reasons of hesitancy? You can get insights from that conversation to develop your strategy for messaging to improve vaccine uptake. In Pakistan, we rolled out some test campaigns recently on the social media platform, and we saw that a local language is important. So people who saw messages that were in Urdu as compared to English remembered the messages more and were more likely to take the vaccine. The intention was higher there. Then other things were value-based messages. So if you worked on fairness or equity or helping others, those messages resonated with them, and that improved their vaccine intent. So did testimonials. So children or young adults saying that I took the vaccine for my grandparents so that I can meet with my grandparents and I do not get them sick, right? And then testimonials from healthcare workers, like a doctor saying why they took the vaccine. They took it for their patients so that they can take care of their patients. All of these improved the intent to vaccinate. Um, with regards to misinformation, we have seen an increase in misinformation during this pandemic, especially with the vaccines. A lot has been said. People would have seen videos and memes being circulated on different platforms, including social media, which conveyed mis or disinformation. Uh, we have actually published a guide, a field guide on tackling misinformation. It can be found on the Yale Institute for Global Health website. Some important points include social listening. So you need to see what is being said, what misinformation is being circulated. Uh, and then another important point is to understand that misinformation. What is the reach? What are the concerns that are being showcased, right? And then understand what level of risk that misinformation puts the population at, and whether responding to that misinformation is likely to increase that misinformation itself, or the risk of not responding are higher. So there is this understanding process that goes on, and then you can get to the response process, which is debunking that misinformation, right? And there are a few steps that go into debunking. So you need to start with stating the fact. You need to say that this is the misinformation that has been uh, that is being said. What's the fallacy in this misinformation is important to communicate. And then finally, once you communicate that fallacy and the misinformation, you create an information vacuum, which needs to be replaced by another fact. So you start with the fact, you debunk the misinformation, talk about the fallacy, and then you replace it with the fact again. And that can help decrease the misinformation that is being communicated. I guess I will stop here.
No, there's so much to say about it. Well, while I mean, experts like you, they are trying to dispel all the myths and make the information more and more credible. This vaccine, this virus, it keeps on changing, and Iram Azadi, she has shown slides from alpha to delta. So, I mean, I don't say rumors, but the grapevine is that the delta is also going to change. So tell us, I mean, why there are so many variants, or is it true for all pandemics, or is this really very different pandemic? And how much we as people should be concerned about it, and what's the thinking in the scientific community, and what are the public health practitioners concerned as well?
So this virus behaves like other viruses. We know the flu virus mutates. It mutates every year. We get a new strain of the flu virus each year, and therefore there is an annual vaccine that goes with it. This virus is no different. It mutates, and the mutation that successfully circulate confer a fitness advantage to the strain. And that can increase the transmission and may also increase the severity of the virus. We have seen that with Delta is more transmissible than the other strains. And if the virus continues to behave as expected, it's going to mutate again. And a new strain which has a better fitness will replace the Delta strain at some point, right? Currently, the good thing is, as far as we know, vaccines are effective against all known strains. This may change in the future, but currently we are protected if we have the vaccine. Right. The important part is that as the cases increase, there are more chances for the virus to mutate. As it transmits from one person to another, the number of transmissions increase, the probability of mutation increases. And hence it is important that we vaccinate the large chunk of our population globally so that we can stop those transmission cycles and hence decrease the probability of mutation. Similarly, use of non-pharmacological interventions are important over here. So masking is very important. Masking prevents transmission, both it protects the wearer from getting the virus and from transmitting it. And in situations where we do not have high vaccine coverage, these non-pharmaceutical interventions become very important. We saw that in childcare settings where there were policies where children wore masks. We know children are not eligible for vaccines right now. Well, some of our data is even pre-vaccine period from May or June of 2020. We saw that childcare settings which instituted early mask wearing for children had fewer COVID outbreaks that caused their centers to close in 2021. So these NPIs really help.
Okay, Dr. Malik, now this is very interesting that it means that we have to go for vaccines, we have to go for NPIs, we have to address the fake news and misinformation, and stigma is of a different kind as compared to TB or HIV and AIDS. But yes, there is a stigma, and you must have heard about those sad stories from Pakistan and from other countries in the world. What happens at the funeral, how people were isolated, shunned virtually from the communities. Now we will be talking about the surveillance, because that's very important. We should know that how we are doing and how we are addressing, and the World Health Organization has really underscored surveillance. So you tell us that what are those aspects that should never be forgotten while doing surveillance of this particular pandemic, and as an expert in the field, what do you think are the areas that need further improvement? And one supplementary question that do you have any special advice for Pakistan regarding surveillance?
Thank you for that question. So as we saw earlier as well from Dr. Zadi's slides, that trends are really important. It is important to monitor the trends of whether the cases are going up, are going down, what's the amount of testing that is being done, the vaccine uptake, and all of this falls under the domain of surveillance. So when the pandemic started, the surveillance was very poor. It did not matter where you lived, the surveillance wasn't up to mark, and the cases were highly underreported. It improved over time. It really picked up. Deaths were being reported much better than the cases, even in the earlier period, but the cases were not. But then some novel surveillance methods came in. So use of sewage surveillance has been really important over here. So you can actually monitor sewage outflow to see if there is virus in the sewage. This virus, it is a respiratory virus, but it gets excreted in the human waste, and then goes into sewage, and you can monitor it from there, just like how polio monitoring is done. So in Pakistan and other polio endemic countries, there is a sewage monitoring of polio circulation. Similarly, you can do that for COVID. We initially did a pilot here in the US in New Haven, Connecticut, and showed that spike in sewage preceded spikes in hospitalizations and cases by 2 to 3 days. That actually gives you time to prepare your systems, right? If you see a spike in sewage, you can better allocate resources because you would know that the cases and hospitalizations are going to go up in the next few days. So it gives you some breathing space. So that is important. This work is also being done in Pakistan. So the National Institute for Health, Islamabad is doing it. So is the Aga Khan University. AKU is also doing sewage surveillance for COVID in Karachi. And sewage, you can also genotype the extractions from the sewage, and you can also see what strains are in circulation. So that can also help inform the genetic variation that might be in circulation at any time. Coming back to the original surveillance, so surveillance improved in Pakistan as well when we started testing more. We are still not testing the asymptomatic cases as much as we should be, but there are logistics and other factors that go into that. The NCOC has been great about responding to the surveillance data that they get. They have been monitoring the surveillance data in Pakistan with cases, with vaccines uptake, and have been duly responding to what they see in the data. So they are being informed by it. And that has to some extent helped keep the cases low. We haven't seen as high spikes in Pakistan as in some other countries. So data-driven approaches are helpful here.
Yes, as a Pakistani, I'm really very proud of NCOC's performance. Really, I mean, it is remarkable. It's very organized, and I mean, for the first time, actually, I'm seeing, data-driven decisions. So we have been talking about, vaccines. We briefly touched on the politics of vaccines and, economic hostilities. And there is a gap. There's an obvious difference between rich countries and not so rich countries and really poor countries. So your comment as a public health expert, and there is one supplementary question as well. I know you're from very elite medical school of Pakistan, but in general, Pakistani doctors, medical doctors, they think that there are certain things that is within their domain. And most of the things that affect health sector, they are actually outside the health sector. So what can they do? I mean, I'm not blaming them. I'm one of them. But when we study and practice public health, it seems that, oh, we are so powerful and everything actually falls under public health. And so, I mean, what do you see the situation? I mean, how public health, so one question is this, that what is your comment on this vaccine distribution and dosages between rich and not so rich countries? And then what public health practitioners and experts and influencers can actually do about it, because it's a political choice as well. So over to you, Dr. Malik.
Thank you. Thank you for that very interesting question. We know that, in high-income countries, greater than 60% of the population is vaccinated. In low-income countries, that rate is less than 5%. So there is a very large global inequity in vaccine access and distribution, right? And it is important that we have a global equity because vaccines save lives, and rich countries donating their excess supplies of vaccines to other countries would help save lives further. So that is, and there is a definite equity argument over there. There is an ethical, moral argument for that. But another argument is that it is in the national interest of these high-income countries to donate vaccines. Modeling studies have shown that if there are excess dosages in countries that are close to the herd immunity threshold, donating those excess vaccines to other countries would help in decreasing importation of the virus in their own countries. So they wouldn't import the virus in their countries, they wouldn't see a case spike, and can effectively keep their borders and their economy open. So they don't have to place travel restrictions. They do not need to close down their borders. So it is in the self-interest of these high-income countries to donate. This hasn't materialized as much as yet. We know the current U.S. administration has promised increased donation of vaccines, but that will be materialized mostly in 2022. A few months down the line. But these donations and these sharing of vaccines need to start happening right now so that we can effectively control the circulation of the virus in other countries and any importation that may result. This can also decrease the emergence of variants. So when you donate vaccines, you get other population immunized, you decrease the transmission cycles, and that can decrease the probability of transmission, probability of variant emergence. And so there are a number of different arguments for global equity of vaccines that should be done. With regards to public health professionals and public health implementers, I think it is important that they voice their concerns. They should communicate clearly that this needs to happen and pressure the leadership into taking action with regards to this. The other thing that the public health community can do, and not only the public health community, but the practitioners, the clinicians can do as well, is to promote vaccines, right? We know that people trust their healthcare providers. They are a trusted source of information. If my doctor tells me to take X, Y, and Z test, I'm most likely going to do it. Similarly for the vaccine. So if my provider is going to recommend me to take a vaccine, I will take it. And that is where the community can play a big role.
Yes, without, community involvement and participation, rather partnerships, this would be impossible, to address this pandemic effectively. We have done so much remains to be done. But I was actually thinking that this would be the last question, but since you have said that public health practitioners, they should voice their concerns and they should be able to pressurize the leaders. So if I may ask you that, what three things they should be telling to those who can make a difference? I mean, those who are in the power corridors, the leaders, the political leadership, that, hey, if you do, you should be, paying attention. You should be allocating more budget to health systems or to frontline workers, whatever, because you know that how much we spend on health and related departments. So, what three things from advocacy point of view, from public policy advocacy?
Okay. So certain things that we can say is we can, again, data-driven approaches really help. We can show them the inequity in access that is present, the communities that are unable to get access to the healthcare, and why it is important for them to have access. Okay, the other is we show them the interest argument, the national interest arguments, that it is in their interest, in the larger community interest, to improve these vaccines rates. And then maybe we can also talk about the global picture, the moral and the ethical arguments that go with it. It is important to clearly communicate what the current scientific outlook looks like and what the current science is saying. There is a lot being done. We need to clearly synthesize that into a clear message that can be given, which is, and it's not only that, we should also highlight steps that can be taken. So not only highlight the problem, but also highlight effective solutions that can be acted upon.
Exactly, and I look forward to the day when there would be, more effective operationalization of gender-sensitive, inclusive epidemiology and more empathy. And this pandemic is really a wake-up call to reprioritize and rethink priorities in health sector and on development agenda. So, Dr. Malik, thank you so much for sharing all this information, your expertise and your advice. And I'm really feeling more knowledgeable. And I'm also feeling optimistic, because so many scientists, researchers, they're doing hard work and at different fronts. And of course, a lot of respect for the frontline workers. So this ends, my questions. And now it's over to the representative of U.S. Embassy in Pakistan, provided there is no question, because both the speakers, they were so eloquent and they were so clear, and I think they have touched nearly all relevant aspects. Still, if there's a chance for questions, most welcome. Otherwise, it's over to you. And thank you very much, PUAN and U.S. Embassy in Islamabad, for giving me this opportunity. Thank you so very much.
Great, thank you so much. And if it's okay with everyone, and Shanila, I'll pass it over to you in just a second. We'll do a group photo op. But wow, thank you everyone so much for this super fascinating conversation on the future of COVID and for providing so much data on vaccines and variants. I want to especially and sincerely thank our three guests today, moderator Dr. Rakshinda Perveen, speaker Dr. Amin Malik, and speaker Iram Zaidi. Thank you so much for your time, expertise, and willingness to share with us today. And on behalf of the U.S. government, we thank you for sharing your knowledge and passions with us. So before we end today's program, if it'd be okay and if everyone's willing to take a quick photo together, if you'd kindly be willing to turn on your cameras, and I'll pass it back to Shanila so that we can grab a quick group photo. Thank you.
Thank you so much, Elizabeth. Thank you so much, Dr. Rakshinda. Thank you so much, Iram and Amin, for the wonderful discussion and informing us by giving us first-hand information. So let's wait for a couple of more seconds so that those who want to be part of our group photo can turn on their camera, because I can still see like around 8 non-video participants. Let's wait for 10 more seconds and then we can click our group photo. Okay, so for our non-video participants, I'm assuming that they want to be part of the group photo. So on the count of 3, I would like all of you to please give me a lovely smile. On the count of 3, please. 1, 2, 3. Perfect. Thank you so much, everyone. Can I take one more? And in this, I would like you to make some kind of gesture, probably a V sign. Thank you so much. On the count of 3, please. 1, 2, 3. Perfect. Thank you so much, everyone. It is a pleasure to have you all. And thank you so much to our panelists once again for informing us about this critical issue. With this, I am pausing the recording over here, and subject to clearance, we'll be posting this on our social media as well. Thank you so much, everyone. Looking forward to meeting you next month as well on some other topic of mutual significance. Thank you so much. Bye-bye. Allah Hafiz. Good evening.
Thank you.
Thank you.
Bye-bye.
you.
Thanks.
Thank you once again for everything and taking the time out of your schedules to have this conversation with us. So thank you.
Take care, everybody. Bye-bye.
Bye.
Bye.